Really looking forward to the session. Go ahead, Sumega.
Thank you, Becca. Good morning, good afternoon, good evening, everyone, from wherever you're joining us today. A very warm welcome to the speakers and the participants. We thank you for joining us today for the second meeting of the PAN and WGH Gender Working Group. For those of you who are joining us for the first time today, this group provides a platform for members to share insights on gender equity within the ongoing pandemic prevention, preparedness, and response processes. Our all-round meetings take place approximately once in every 2 months. I'm Sumega Asthana, the co-chair of the working group representing women in global health. I'm the co-founder of the Women in Global Health India chapter and also a health policy researcher at Georgetown University Center for Global Health Science and Security. I'm joined by Autumn Lerner from PAN, who will shortly introduce herself. But before we begin, I just want to take a few minutes to share with you the highlights from our first meeting in March, where we discussed gender equity and health workforce and PPR. We were joined by Dr. Berio Kripke, the incoming CEO of Africa Public Health Foundation, and Dr. Mary Clare from Women in Global Health Kenya chapter. That meeting, we discussed all of our discussions centered around gender equity and health workforce in PPR. We started hearing from Dr. Rupa Dutt, the Executive Director for Women in Global Health, highlighting our 5 asks from member states around representation of women members in decision-making bodies, provisioning of fit-for-purpose PPEs for health workers, maintaining essential maternal, neonatal, and child health and sexual and reproductive services during the health crisis, prevention and response to sexual harassment and violence against women, and social protection and fair and equal remuneration for women health workers. Dr. Mary emphasized the dominance of one gender and the absence of the other in determining the health systems and pandemic response policies in decision-making spaces. We also heard from her about the issues around PPEs shortage and their fit. Dr. Beery stressed that the issue of gender equality in health workforce is everyone's business, and every one of us should be considering these issues. She stressed on applying the equity focus to minimize impact for future events and said that we will not be prepared for future pandemics till the health workers' issues are not addressed. We concluded the meeting with the idea on engagement from the group and discussed reviewing key policy documents from different countries, especially the Spain's health strategy, the EU strategy, the feminist foreign policies. We also decided to focus on advocacy for member states to support issues of health workers and the INB and the other processes, and identify common interest groups and use targeting messaging to shape priorities for different groups and bodies. But today we're joined by 2 amazing speakers, Kim Sales and Clare Wenham, and we'll focus our discussions on the INB and the IHR processes. I'll take a moment to introduce our speakers. Ms. Kim Sales is the co-convener of the Women in Global Health Philippines chapter and is actively involved in promoting gender equity in health. With a master's degree in international public health from Liverpool School of Tropical Medicine, Kim has made significant contributions to the field, including leading health research agenda development in Philippines and collaborating on various health policy and systems research. She's also served as the Deputy Director and board member at the Alliance for Improving Health Outcomes. Next is Dr. Clare Wenham, who is an academic expert in global health security, global health governance, and global health policy. She's an associate professor of global health policy at London School of Economics. She has a PhD in international relations, and her research seeks to understand how state and non-state actors prepare for and respond to epidemics, and what political changes there are in global health architecture, and what are the downstream and secondary effects of policies introduced to mitigate epidemics. Her work lies under 3 distinct areas of global health security, global health governance, and gender and global health. Again, a very warm welcome to the speakers and the participants, and I give it over to Autumn, please.
Thank you, Sumega. Good morning, everyone. Good afternoon, wherever you are in the world. My name is Autumn Lerner. I'm a senior director with Pandemic Action Network. And for those of you who are new to the network, or PAN for short, just wanted to introduce ourselves. Pandemic Action Network is a global advocacy network, a platform composed of more than 350 diverse partners around the world and across sectors. We are all united in a vision of ensuring that every country is equipped and is resilient to be better prepared for to be able to better be equipped to prevent pandemics and to be better equipped to respond to pandemics. So that's what brings us all together. We're so grateful to partner with Women in Global Health. On behalf of our global team, it's really a pleasure to welcome all of you from around the world, really introduce you to take the opportunity to introduce yourselves in the chat. Let us know where you're joining us from today around the world. And we, as Megan noted, we have a really robust conversation in store for us today. So thank you all for joining. This will be interactive. So we're going to have, as she noted, a bit of time for our two speakers, but then we're going to open it up for Q&A. So as Claire and Kim are speaking and sharing their introductory remarks, please do keep your questions in mind. Feel free to pop them in the chat. But the more that we can make this as interactive as possible, the better. So when the time comes and the call for questions comes, please raise your virtual hands and we'll have some robust time to get as many questions on the floor as possible. But with that, I would like to open it up to our first speaker. So Claire will have the floor first. Since introductions are done, I always like to turn it over to our speakers first and also have them introduce themselves in their own words in terms of their current work, particularly as it relates to our conversation today, the intersection of equity and gender in the IHR review and IAB pandemic report processes. So Claire, can you, just to kick us off, introduce yourself, and then please describe your work as a rapporteur to the Review Committee on Amendments to the International Health Regulations.
Sure, thanks for having me. It's a pleasure to be here. My name is Clare Wenham, as Samega said. I'm an Associate Professor of Global Health Policy at LSE. And one of the main areas of my work has been for many years now looking at the intersection between gender and health emergencies and really trying to understand how global and national policy making that's written in a gender neutral way can have significant downstream effects across women and other groups and other vulnerable groups at a time of crisis and in the aftermath of crisis. So as part of that, a lot of my work has focused on WHO and the IHR and the impacts of the international health regulations on women and the way that the IHR have been designed and the lack of gender considerations at the time in 2005 when they were established. And I've looked at this in many different locations and different levels of analysis, from the global all the way down to the local, particularly during the Zika outbreak and obviously during the COVID pandemic. I was fortunate enough to be asked to serve as the rapporteur on the International Health Regulations Review Committee for the amendments, the proposed amendments, which have recently been submitted last year to the WHO and for member states to consider, and the process which is currently ongoing in the working group, the International Health Regulations, who are in a process of negotiating these amendments and changes and updates to the International Health Regulations. And I just a kind of caveat, I am speaking today as myself and as my academic hat and not on behalf of the review committee. But I think that there are some really important thoughts that I have about the way that the IHR has sort of initially was set up and how the conversation has developed in subsequent years around the intersection of the international health regulations and gender. If that's okay for me to continue, Autumn and Samega.
Yes, please go ahead. I mean, I think having that overall context and arc of the 2005 regulations in terms of where things have been at from a gender responsive perspective, and then what we're looking at right now, is a really helpful introduction, and then we can get into further details in the Q&A.
Absolutely. So, I mean, again, for those of you on the call who might not know, I'm sure you will do, the international health regulations are the main piece of legally binding legislation that exists globally to prevent, detect and respond to emerging infectious diseases. And they are hosted in the WHO. They are legally binding under Article 20, under Article 19 of the WHO Constitution. And they are ratified by governments across the world as for what they should be doing to in the case of an emerging epidemic. Now, in the 2005 version of the IHR, which I have here in front of me, gender is only really mentioned in two different contexts. And one is how to protect travellers, or making sure that travellers crossing borders aren't disproportionately discriminated against because of gender, as well as other intersecting attributes that are listed. And in terms of representation, of making sure that there are sort of gendered equal representation in the review committees and indeed the emergency committees going forward of the international health regulations. So very much thinking about women just as travellers and elite women as participants in global forum within the WHO. And so really, I think that there's a significant absence there. Right, there's a lack of consideration of all the different ways that everybody on this call knows that gender and health emergencies intersect, and the myriad of ways that women are impacted by both the policies that are written themselves, but also then the emerging pathogens and the policies that are introduced to mitigate the spread of pathogens. So there seems to be a gap here, and indeed this gap has been identified by previous review committees to the international health regulation. So after major outbreaks that have happened since 2005, a review committee has been convened by the WHO Director General to see how the international health regulations worked, and were they able to support and respond meaningfully to the public health threat. Now, in 2021, the review committee for the functioning of the international health regulations during COVID identified this lack of gender as a real weakness. They said that gender should be integrated more into the IHR, and that ignoring gender actually hinders the response efforts of any, at any level of analysis. But the question is, where can gender then be integrated? Now, they suggested that because of the technical and very kind of quite traditional public health nature of the international health regulations, the most natural place to place any gender considerations would be within Article 3, which is the principles. Now, within these principles, there are the first principle there is that the implementation of the regulations is done with full respect for the dignity, human rights, and fundamental freedoms of persons. So they see that actually gender equality, gender recognition, however you might want to define it, should be considered within this human rights framework, which governs and therefore remains a principle of the whole of the international health regulations. So then to speed up to where we've got to now is that what happened in the process of the amendments to the international health regulations, for those who are unaware, is that the member states were invited to submit proposed amendments to how best to improve the international health regulations in the wake of COVID-19 and obviously the previous epidemics before that. And so they were asked to, submit amendments into how best they think the functioning works across multiple different locations. And we saw amendments being proposed for over half of the actual articles within the IHR. There were over 300 proposed amendments in the amendments that were submitted last year. And yet there's a paucity of consideration of gender in those amendments, even still. And indeed, the only place where we saw an increased awareness or the recognition of the language of gender within the proposed amendments was in making sure that there was greater representation, gender representation within broader committees and broader activity within the review committee and the emergency committees. So again, it's a very narrow understanding of gender. Now, you could argue that the proposed amendments to the international health regulations that include a broader scope for human rights, that include reference to this is just the suggested amendments which consider things such as livelihoods, such as equity and access, could have gender within all this, but it hasn't been made explicit. And I personally, and again, I speak on my behalf rather than any of the review committee's behalf, think that that's a real limitation and it's a real missed opportunity. But you know, that's the situation that governments have put the international health regulations in, right? It's a sad state of affairs, but the member states of the WHO haven't proposed amendments to have a more expansive and comprehensive sort of gender transformative agenda within there. I'm very aware I'm just chatting, so I'll pause.
Yeah. Thank you for that brilliant primer. I'd like to kind of put a pin in this conversation for now, because I want to make sure that we have time for Kim's introductory remarks, and then we're going to come back and really dig into things further in the Q&A. I encourage you, Claire, and our audience to think about kind of the so what now. And you know, we're an action-oriented advocacy network. This is a very robust audience to communicate to in terms of, you know, what our calls to action are. So with that, I'm going to turn it over to Samega and to introduce introductory remarks with Kim, and then we'll open it up to Q&A. So please keep those questions top of mind.
Thanks, Adam. So Kim, hearing from Claire about the need for a more expansive agenda on gender and equity in the IHR processes, where do you see these issues being integrated in the pandemic instrument under negotiation?
Yeah, thanks, Samega, for your question. I'll just do a quick reintroduction of myself. I'm Kim. I'm an early career health policy and systems research. I primarily have CSO work, but I've also been working at the National Institutes of Health before, at the Institute for Health Policy Development and Studies. I'm also, I can say this now because I signed my contract today. I'm a program manager for a new program under the National Institutes of Health Philippines on health promotion. So I'm really speaking today from my collective experience across my work and career so far, as well as being one of the co-conveners for Women in Global Health Philippines. So I was able to join some meetings during the assembly about the pandemic instrument. I think that the current version that was released on May, just last month actually, accounts for gender equity or equality provisions in the INB draft in a few sections, like as a general principle included under the human rights. In Article 7, covering health and care workforce, there's some recognition that there is a need to reduce inequalities and disparities for women, healthcare workers, as well as some overall support to improve their working conditions. Okay. And Article 9 as well, for research and development. There's some consideration for gender, but also other intersectional factors such as race and ethnicity in clinical trials. And
Kim, I'm sorry to interrupt you, but we're having audio issues on our side. I don't know if it's your audio phones, your earbuds, but the audio is very choppy.
Okay, let me try.
Or maybe if the video is impacting, I'm not sure.
Yeah, is this better now?
No.
Yeah, let me change my audio settings for a bit.
Okay. Thank you. I apologize for interrupting, but I want to make sure everyone can hear you.
No problem. I'm not sure. Is now okay?
No, it's the same. But if it is the same, let's just continue on.
Just quickly like switch my internet or something. What about now?
It sounds perhaps a little clearer. Let's continue on. Can you hear us, Skip? No, we can't hear you. Oh, I'm sorry. Apologies all. I wanted to make sure that we could clearly hear her, but hopefully we'll get her back.
Maybe in the meantime, we can hear more from Claire on the new processes. Claire, would you like to elaborate a bit more on your point around expanding the agenda, and where do you see this going? What are your suggestions around? And also, what is your take on the new draft instrument that was published on 22nd May? If you can elaborate a bit more on that in terms of the relations to equity and gender equity.
Sure. So, I mean, I guess I'm very happy to hop off as soon as we get Kim back. I guess one of the key points that I find limiting, both in the IHR, the proposed amendments to the IHR, and the treaty bureau text, is this focus on representation and the limitations of that. Now, I am 100% committed to participation and representation of men, women, all genders, all, a diverse mix of people does make the best policy. However, just focusing on ensuring a diverse group of people are in the room, I don't think goes far enough to ensure that everyone has the same ability to talk, for example. Decades of research in feminist studies has shown that, just being women in the room doesn't necessarily make a difference. We have to make sure that there are mechanisms in place to ensure that decision-making occurs in a way which is, based on feminist principles, that we ensure that men and women are having the same opportunity to talk, and it's not just the same voices and the same men dominating in these spaces. We have to make sure that the processes by which, papers are distributed or background topics are made available is done in a way which is also equitable and makes sure that everybody can meaningfully participate. And it's not simply that, women are being put in the room to kind of tick a box. And I think the other part of that is that we also know from decades of gender research is that having more women in the room doesn't necessarily lead to more gender transformative policy. And I think a key gap there is making sure that not only are women in the room, because they must be, but that gender advisors and people with gender expertise in policy making and understanding how policy processes can be gendered and the downstream effects of policy are equally in the room. Because I think just adding women and stirring isn't going to be enough to see transformative action and change, so that the next time a health emergency occurs, women have greater protections put around them. And so I think that, and again, in the INB treaty, there's been lots of comments around representation in panels of experts, in all the different committees that are being proposed, making sure it's equal representation. Like, yes, absolutely, but what else are you guys doing? What else is being put in there to ensure that it's not just for the benefit of, the elite women who participate in these groups, but every other woman around the world, for example, who are going to be impacted by the policy in due course. Is Kim back? I'm very aware I'm trying to fill some time.
Hi, Claire. Hi, Subeka. I am back. Let me know if this sounds better.
This does.
Okay, great. So I caught most of what Claire has said. So I 100% agree. I think that the INB draft at the moment is very big on representation and accounts for gender equity in healthcare workforce, in representation in research and development, clinical trials. And what it does say is that they see gender equity as a fundamental right, and that pandemic response should consider how this impacts women, especially their safety, their access to care, as well as their economic stability, because women are disproportionately affected during pandemics. The Great Resignation is mostly women because of their disproportionate burden of care work, and so they have to be the one that kind of has to
be unemployed to take care of their families. I think to a certain extent, the INB draft also acknowledges that women deliver healthcare. But again, these are languages on representation. But I think we've also seen kind of some weakness in terms of gender equity language. I think a lot of, including the definition of gender equity has been removed. I think the INB draft as well has been kind of weak in terms of incorporating the concept of universal healthcare and primary healthcare in the latest version. And I do think that, you know, pandemic response has to rely, or is universal health coverage has to be one of the backbones of pandemic preparedness and response. You know, we need to have access to essential health services, sexual reproductive health services, especially for women and girls, you know, services to protect women from violence, as well as children. Universal health coverage can also help us address these gender-based health disparities. And I'd also like to point out that financing, you know, is a huge roadblock. I worked on the pandemic response playbook for the Ministry of Health Philippines last year. And I think the biggest hurdle for us is kind of how to marry not just pandemic response, but the Philippines being kind of a hotspot for disaster and emergencies in general, and how to marry that with our you know, 2019 universal healthcare law as we transition to kind of completely changing how our health systems work. So there has to be also some consideration for how low and middle income countries can kind of use the INB draft as a framework or just a mental model for how they will implement universal healthcare and how they can integrate it with disaster and health emergency response. Yeah, I think I'll stop there in case there are additional questions from Subeka.
Thank you, Kim, for these wonderful interventions around UHC and financing and taking more of a holistic view to the instrument. We'll just move forward to the next set of discussion on the policy one-pager that we've developed. And as you know, the 5 R's and the recommendations that we have in place related to gender equity and health workforce, I'll just repeat it for our participants today. They are around women's representation, decision-making and governance structures, prevention of sexual exploitation, abuse, fit for purpose PPEs for health workers and care workers, equal and fair remuneration, and for health workers, and maintaining SRH and MNCH services as essential during health emergencies. So we'll start with you, Kim, to understand in your perspective, where do you see these recommendations fitting in the given INB negotiations, and then we'll move to Claire to hear about her thoughts as well.
I think most of the policy positions are well represented in the INB, in the pandemic instrument, but I would say, again, to Claire's point, meaningful engagement is kind of what we need. So it's not just about gender, right? Like, we can look at intersectionality of gender, race, and ethnicities. And I very much agree that being just in the room is not enough. There needs to be a more deliberate, meaningful engagement of different backgrounds and different contexts and people with lived experiences about these high-level policies. I do think there's more room on the language on the continuous sexual reproductive health services during pandemic response, you know, to prioritize it as an essential service that must be maintained during an emergency or a pandemic. Prenatal, postnatal care, safe delivery services, contraception, safe abortion care, where that's kind of legal. I think some, you know, during the pandemic, we saw some innovations, such as in the Philippines, at least door-to-door delivery of contraceptions. But again, I feel like that shouldn't really just, again, to my point of universal health coverage, that really shouldn't just happen during pandemic response. You know, I think these interventions or thinking about how to reach geographically geographically isolated and disadvantaged areas should actually be part of how we normally and typically deliver these services. So that includes, I think, consideration for supply chain issues, training and supporting healthcare workers so they deliver these services regardless of emergencies, but also especially during emergencies, but also how we kind of deal with gender-based violence, which did see a significant increase globally during the pandemic because of the impact of pandemic-related restrictions in movement during its height. So for me, that's kind of how I see, where we can improve based on the policy positions in the one-pager. Thanks, Sumeka.
Thanks, Kim. Thanks for bringing in these important ideas around meaningful engagement and intersectionality and touching upon the lived experiences, geographical disadvantages. I'll move to Claire. Claire, what do you think? Where are the space for our recommendations in the IRB negotiations?
Sure. So, I mean, I think some of the recommendations that you've made in your policy one-pager are quite, front and center of the spaces where we do see gender engagement in the IMB negotiation or the draft. So, for example, the trying to get at least 50% representation. I think we see that across the push for greater representation amongst committee groups, and that's both actually in the IHR and in the IMB. So I think that's one stage. I guess my question, the kind of the flip side of that, building on what I said before, it's not just about having women in the room, but I think the other part is, are these committees that are being pushed to have gender representation actually where decisions are being made? Right? Or are they expert groups that are feeding into decision makers? And so I think we need to make sure there's not a step missed out there in the kind of, evidence. And I think particularly as we are, there's multiple reviews going on at the moment around kind of the politics of evidence and how evidence gets informed into pandemic decision making. And certainly in my country, in the UK, this is a hot topic of conversation around how science was used or not used by decision makers. I think that's something we need to think about, that these committee groups aren't being equated with decision making, because I'm not sure they necessarily are. I also think that there is meaningful inclusion of gender, of the kind of the gendered impact, or rather the gendered needs of the healthcare workforce in the IMB Bureau draft. Now, admittedly, I think it's been watered down since the last version, but I think that is there, right? And that certainly isn't present in the IHR. So I do see that somewhere that, the work that Women in Global Health have been doing to really push this up the agenda is paying off and having some effects. I guess, the question is, how do we make sure that these and the other ask if and when they come in don't get watered down through the negotiation process, because I think we're seeing them getting watered down already, right? The fact that we're seeing in Article, is it 7, the kind of gender responsive in brackets, gender sensitive in brackets, and we're seeing language being taken out of the draft. And my sense of what's going to happen over the coming year is that these sorts of issues are going to be the first to be negotiated out as governments push for what they think are more politically pertinent issues. For example, access to vaccines, access to medical countermeasures. The big hitters of the pandemic treaty negotiations, I think, might mean that other parts such as this get watered down, which would be a real shame. But I think you've got clear, demonstrable impact of these policy asks in the treaty.
Thank you. This is really insightful, and your points around, experts group and not just women and not just tokenism of representation are extremely important. But my next question to both of you is, you both have emphasized the threat of the language being taken out, and also stress the importance of language edits and stressing on using a particular language. Where do you see the role of civil society organizations like Women in Global Health and others in our participants today what do you recommend for these organizations to use these asks and messages to advocate for stronger language on the issues? How do you see that unfolding? Do you have any recommendations? We'll start with you, Claire, and we'll move to Kim.
Sure. I mean, look, my honest opinion is that it's only ever going to happen through civil society groups pushing that we're going to get gender on these agendas, gender on these pieces of these international instruments. I think there's only a handful of governments that would be actively trying to put these on by themselves without having that push from the domestic level up and from civil society groups. So, you know, a big push and pray and thank you to everybody on this call who's involved in getting gender onto these instruments, because it's, you know, thanks to all of your hard work. I think it's just about continually pushing, right? Continually pushing. And when you're seeing things being taken out, asking the question of why and pushing to get them being put back in. Now, obviously, you know, these instruments can't have everything and they can't do everything. We can't expect them to do everything. But it does seem a real shame to have this opportunity for learning, to have had the, you know, devastating impacts, the gendered impacts that have happened to everyone around the world in the last 3 years, to not be a moment to try and actually recognize that in future instruments to try and mitigate those effects in future seems like a real wasted opportunity.
Thanks, Claire. Over to you, Kim.
Hi, Suneka. Thanks for that, Claire. So yeah, most of my years so far has been working in CSO, so in the Philippines. So I think what you know, never miss an opportunity to learn from a pandemic, right? So what have I seen in my experience in the Philippines? It was actually CSOs that were pushing for public health, the public health perspective, and as well as the equity perspective. And I think, like Claire said, CSOs will play a big role in this policy window space. Just to build on that, you know, just as this the Pandemic Action Network and collaboration with WGH is doing, I think coalition building and continuing to coalesce with other CSOs that are for a gender equitable pandemic response and health system is always a good strategy to show that there are so many organizations. This is a very clear policy priority for us and the communities that we help and try to represent in these discussions. And this hopefully will increase our policy influence. I also would say, this might be obvious, but maybe not all the time, but you know, using strong evidence to make a more compelling case for a stronger language on gender equity is something that I would like to advocate for, instead of kind of just blasting awareness that, oh, we should be including gender equity. But you know, I think it's always good if we also use compelling evidence to support our advocacy. And finally, I think we should definitely be including the voices of people with lived experience, in whether it's in our countries or communities. They're very effective, I think, in communicating exactly why women are, how gender is a social determinant to health, and how we are disproportionately left behind in times of health emergencies and other crises. So that's it.
Thank you. This was really helpful, and I'll reiterate the points around CSOs are the only organizations that are required now to be in more action and pushing collectively in coalition building, and especially the point around the stronger evidence and including the voices of people with the lived experiences. This has been really insightful. I'll give it over to Autumn now to take us to the next part of the discussion. Thank you.
Thank you. So as we promised, we do have some time for Q&A. This is the portion of the working group where we put the working group. Encourage those of you who can to turn on your video. So this is more of a discussion. We can see each other. Please raise your virtual hands if you have questions or a very topical intervention or comment as it relates to the subject matter of the IHRs and the IMB negotiation process. You know, the next year is very critical as it comes to the IMB, as we're looking to finalize this process by the next World Health Assembly next May. And while we're waiting for more questions to drop in the chat, there was a comment from Tala about kind of the language that we use with regard to gender representation and women's representation, understanding that gender does not automatically mean women. And yet there's the piece of this in terms of women really leading and driving the workforce. So there was a bit of a two-part question, one about kind of the language that we use, and Claire and Kim, I think it would be helpful to get any recommendations or thoughts or frameworks that you actively turn to. And then there was a second question that was really about where we put our money and our funding, considering that women are driving the health workforce. What is being done, particularly on the financing side, to really change how money is being directed to go directly into community-based and women-led grassroots organizations that are on the front lines. So I'll open it up with that. And then I see the questions are starting to go in the chat, which is great. I encourage people to raise those virtual hands. Claire or Kim, any responses to those opening prompts? And then if yes, great. I see Claire went off of mute, so I'll turn it to Claire. And then I see David's hand is up and then Leslie's.
So yeah, in response to that first point, absolutely gender is not just about women, but I think that the way that it shouldn't be, right? That's why we should be using feminist frameworks which consider mechanisms for understanding unequal impacts and disadvantages, which don't just limit it to women, but can limit it to any particular group or any group. And it's those frameworks which allow you to unpack what's going on, you know, outside of policy circles, what's going on the ground, what's going on at the margins. And those are the people who need to be protected the most. So, you know, I would be an advocate for more feminist language rather than language of gender or language of women. Having said that, we do know that it's women that make up, you know, 77% of the workforce, right? The healthcare workforce. And, you know, we shouldn't lose sight of that, right? And lose sight of the fact that it is women and it is particular needs of women within that, such as the ask around, you know, PPE that fits, you know, bodies, for example. And, you know, without disadvantaging any other group by saying that, I think it's important that that is not missed in a push to ensure accurate language.
Thanks, Claire. Kim?
Yeah, I mean, that's a great response. Like Claire, you know, women responsive is not the same as gender responsive. And I'd just like to emphasize that. I think going back to what I said about evidence-based advocacy, just keep driving the message that women deliver health, but men lead it. We are disproportionately affected during pandemics, and it's very important that, you know, feminist frameworks, women responsive language is very explicit, because, you know, it is women that take the brunt of the pandemic. They are kind of the frontliners during the response, as we've learned during the pandemic. So I think Claire summed it up perfectly.
Thanks, Kim. David, we'll open it up for the next 3 questions because I see 3 virtual hands raised. And also thank you everyone for your feedback on the policy one-pager in the chat. That is helpful. So David, question, then Lesley, then Arush, and then we'll turn it back to Claire and Kim to react to those 3 questions. And if there are other questions on the floor, please raise your virtual hands, or if you're unable to voice your question, please put it in the chat.
Yeah, thanks. David Bryden from the Frontline Health Worker Coalition. It's a fascinating discussion. Thank you so much for this meeting today. Just one, when it comes to some of these issues, what really strikes my interest is the requirements for how money should be spent. And so the INB process is important, and what we're talking about with the treaty and so on, but I tend to gravitate more to like what are the actual requirements for money, and so there I'm interested in what are the requirements for successful applications to the pandemic fund, for instance, or bodies that are putting forward applications to the pandemic fund, or the global fund to fight AIDS, TB, and malaria. We know it has a COVID response mechanism that will be ongoing. What are the requirements for the composition of bodies that submit applications, or how are those applications scored? Those are some of the issues that I don't know if there's been any analysis of that from the point of view of gender specifically, or inclusion of health workers, for instance, in decision-making bodies. If you look at the guidance for formations of the country coordinating mechanisms of the Global Fund, there isn't much specific mention of health workers. For instance, there's mention of women. There's some mention of gender. So it's a bit of a mix. If you look at the CRM-19 mechanism, there's some guidance there too, but it seems to be missing a few things. If you look at the pandemic fund, there is an interesting indicator. I think it's number 4. I'll just put in the chat a link to the indicators for what the proposals need to, how they'll be scored. And there's one there on gender that's pretty interesting and looks really good. But how have women and how have health workers included been included in the formation or development of proposals to these mechanisms? I think with the pandemic fund, it's still, and maybe the jury is still out on that, but I don't know if there's been any analysis by any of our speakers or others on the call about how these funding mechanisms are working in this area.
Great. Thanks, David. Lesley, over to you, and please do introduce your organization as you share your question. Please keep your questions as brief as possible so that we have time for full responses. So Lesley, Arush, and then Clara, I see your hand up as well.
Thank you so much, and thanks for bringing us together. I'm Lesley Odendal from AIDS Funds, which is a Dutch-based HIV-specific organization. Most of our funding goes to what is in the HIV sector called key populations, so kind of the most marginalized groups being the LGBTQI community, sex workers, and drug users. And I think I just have quite a general question for reflection, which is around, when we speak to these groups, a lot of them feel that particularly the kind of work around PPR and the upcoming high-level meeting on PPR are very like northern-based, quite exclusionary, or it's just not making its way down to the communities that are most affected by pandemics and that will be most affected by the pandemic accord. So I've been thinking for myself in my position, how can we change this? And so maybe it's just a reflection to the broader group. How can we switch this around, especially in the wake of the anti-gender movement that is so strong and is outfunding us by vast amounts and is really suppressing these groups and making them go underground. I'm based here in South Africa, and it's, we're really seeing the effects on the continent. So I would love to just hear some ideas from everyone and also just bring the issue to our attention. Thank you.
Thanks, Lesley. Arush?
Hi, everyone. Thanks both Arslan here with Women in Global Health, but also at LSE, where I have the privilege of working closely with Clara as one of my supervisors on my PhD. I was wondering, I kind of had two points. The first is kind of a comment, but I'd like maybe either of your feedback on it, which is, while I think we've been pretty happy with Women in Global Health that most of our inputs have somehow been reflected in the current draft. One of the ones that for me strikes me as surprising that has not been included anywhere is the language around prevention of sexual harassment, abuse, and exploitation, especially in the wake of all the scandals and everything that happened in the mass emergencies. I view this as something that should be almost a no-brainer, and I don't know why we're struggling so much to get member states to input that in. So maybe any thoughts on maybe ways we can maybe push that, that would be very helpful. The second one is more of a question. Claire, I know Claire's her research has done a lot of really good insights into accountability, and I think that's where a lot of the part of the reason the whole accord was built in the first place, and the failures of the IHR to for countries to actually comply with them. And I guess I'm wondering if maybe, Claire, you have maybe any insights on where you find the most hope in terms of getting accountability in this. Is it through something like pushing for the Global Health Rights Council? Is it maybe institutionalizing it through more mainstreamed language or referring to more preambular text that's already been well established? Kim brought up the really good point about financing, and maybe we need to almost institutionalize more, kind of codify some language around mainstreaming this into financing mechanisms so we actually know, people take them up. I don't know, any thoughts from either of you around accountability and making sure this work actually gets done? Thanks.
Thanks, Farouche. And then Clara, over to you. Laura, I see your hand is up. We're running short on time. I want to make sure that Claire and Kim actually have time to respond. So please put your question in the chat and we'll do our best. Clara.
Hi, thanks for giving me the space. I am Clara. I'm an independent consultant on gender and health, working with a number of UN agencies, including WHO on and off. So I think what I'm interested in seeing is, and hearing from the speakers today, is how can we maybe find progress by working on the, what we call the two-track approach, right? So on programming for gender equality beyond health, we usually work on this two-pronged approach, right? Where we have a concerted effort that is targeting and addressing specific gender inequalities, and then also in mainstreaming gender. And from my experience in global health, the elements of integrating the use of, for example, gender data into preparedness, response, and recovery is one way to kind of bring the focus into making our systems more effective and efficient, and a little bit touching on the evidence that Kim was referring to, on how by including this data, for example, but we will be making our systems more efficient, and therefore, reaching the goals of the IHR, et cetera, et cetera. So whilst still maintaining this very important focus on representation, visibility, being in spaces where decisions are being made, et cetera, I also see an important role, especially for CSOs at the local level, to feed into systems that say, hey, this is how this community works, and this is what your system should take into account in your design of prevention policies, response policies, etc. What I am a bit more unsure about is how is there a space in the current mechanisms that are being discussed to introduce these elements, right? Or are they at such a high level that we cannot see it? Maybe it's in the requirement tools that I think, David, was it you that was alluding to them in the requirements for approval of funding, or also I was thinking about how do we measure success, right? Is it success that we contain the disease, or is it, the distribution of the disease and who is most affected, et cetera, right? So adding those elements into even the definitions of how are we measuring success of these global agreements. Thank you.
Excellent. Thanks, Claire. Great kind of prompt for us to get really specific. So Claire and Kim, I know this is ambitious, but you each have like 2 minutes to kind of pick and choose and respond to the things that are most salient. If there's anything else, please feel free to put it in the chat. I wish we had more time. It's obvious that this working group is so important. Claire, over to you, and then Kim, over to you. And then we'll wrap it up with a quick little bow.
Sure. Thank you so much for all those questions. And I'm not going to answer all of them because I don't have time. Clara, in response to your point, absolutely. I mean, it's not just about having these high level proclamations. It's about making sure you've got the evidence that Kim was talking about before, and using all the different metrics. And it's also about talking the language that health policymakers understand. So it's, gender metrics and indicators are important, but so too are using public health metrics and making sure they're disaggregated, right? And using the tools and the language that these policymakers will understand. And obviously, Clara, your work, about this more than anyone, and we're seeing starting shifts around this, right? Such as the JEE expansion to include gender indicators. And this kind of links into David's question around following the money, right? Because if now they're going to be using the JEE as the baseline for the pandemic fund, and as countries start to implement the latest rounds of the JEE and you start to have these gender indicators, that might be a tangible way where we can start to actually look at how gender and the impacts, or how countries are considering gender impacts, are featuring into decision making around funding. However, I think it's too early to see actually if that's going to work yet, right? And if actually it's going to be a meaningful comment or anything that anyone's ever going to consider in a funding decision making board. And just one comment in response to Arush about the compliance and accountability, because I think this is a huge problem, right? Which is because we don't know how different parts of the treaty are going to be implemented and which bits are going to be legally binding and not legally binding. And in a framework convention, which bits might be ratified and not ratified. It could be we're in a situation where actually the parts that are relating to gender aren't ratified. Right. And then you're going to be in a situation where governments aren't going to be held accountable to it because they haven't signed up to those parts of it. And so I think it's very much I think we're putting the cart in front of the horses if we're thinking about how we're going to hold countries to account before we know they've even signed up to it.
Excellent point. Kim.
I'll do this quickly because it's like 3 minutes, right? Till 10 p.m. here. So on the pandemic fund, I actually was able to ask that question on a side event during the assembly, and I was a bit not satisfied with the answer. I think they said something like, oh, it's one of the indicators when we assess applications. Most of the applications they've received are from LMICs. I have seen the indicators, but I think I don't have an answer, but what I would be more interested in is like how much weight does the gender equality indicator have in terms of making the technical review committee's decision on who to award the pandemic fund to. On the issue of data and accountability, well, just accountability, I think data is very important. And women have always been kind of invisible in terms of how we design our programs, and specifically on how we design monitoring and evaluation data. And I think it's very important that as the pandemic accord is implemented, that we make sure, how can we make sure that the monitoring and evaluation data is participatory of women or is inclusive of women disaggregated data. And I think that's one of the ways in which we can make sure. I'm all for, I said this evidence-based advocacy, but actually the very big hurdle for us is how to make sure that women are not invisible in the data, as we have always been for so many years. And how do we make sure that women are well represented, and that it's just not very generic questions that don't take into account, that are not women responsive or are not gender responsive questionnaires on how we're doing 5 years, for example, after the pandemic accord has been implemented.
Thank you, Kim. And thank you, Claire. Thank you to all of you who have joined us early morning, late night. I know it's very late in the Philippines right now, and appreciate all of your commitment to this work. As I noted in the chat, our next working group is in July. This conversation can, it definitely has momentum and can just keep on going. So please stay engaged with us through Women in Global Health, through Pandemic Action Network. I also dropped information in the chat in terms of how to get in touch. So thank you all, wishing you a pleasant evening, a pleasant day, and we will see you soon. Take care.
Thank you everyone for joining. We'll see you soon in July.